Yes, sir, we are live. We can begin.
Okay. Welcome all. I welcome you on behalf of ISAR. Today's lecture will be delivered by Dr. Sujata Kar on the subject of controversies and consensus in the management of recurrent pregnancy loss. Dr. Sujata Kar graduated in 1986 as one of the best undergraduate students. She has received 7 gold medals in her final MBBS. She is the first IVF center she has set up in eastern Odisha, and more importantly, presently she is the honorary treasurer of ISAR. She has taken her ART training program teaching from Professor B.N. Chakravarti. She is a visiting fellow of IVF and ICSI program from Harley Street Fertility Center, London, and she is certified training in advanced 3D 4D ultrasound. So we welcome Dr. Sujata Kar to start her lecture. Over to you, Sujata.
Thank you so much, Dr. Kedar, for this introduction. Dear friends and colleagues, thank you very much for joining in today and welcome to this unique academic enterprise from ISAR, the Indian Society of Assisted Reproduction, and DocMode. As Kedar said, I am going to be talking on controversies and consensus in the management of recurrent pregnancy loss. Now, you'll all agree that what the brain does not know, the eyes cannot see. This is very, very true for recurrent pregnancy loss. The only thing is that in recurrent pregnancy loss, we need to know a lot of theory, but we won't be seeing too many and we won't be doing too many. Before I start, let me give you some interesting statistics. 1% of women of reproductive age suffer from RPL. Recurrence risk and subsequent outcomes are similar for women with 2 or 3 losses, and therefore, this is the rationale as to why you may start investigating after 2 losses rather than wait for 3 losses. First trimester losses are up to 75%, and second trimester losses are up to 25% of cases of RPL. RPL rate is 50% in women more than 40 years. And the most important and unfortunate part is the etiology may be established in only about 30 to 50%. And in the vast majority, the etiology of RPL is unexplained. And of course, RPL has a high impact. It causes extreme distress in the couples, understandably. Unfortunately, in the doctors, it causes extreme frustration because there are many causes, there are so many investigations, there are very few treatments, and there are even fewer clear cut guidelines as to how to treat and manage RPL. So, today in my lecture, I'll be covering in this order initially the definition, understanding the various etiologies of RPL, and current recommendations on how to evaluate, prognosticate, and treat RPL. And today I'll be taking most of the recommendations from the latest ASHRAE guidelines of 2017 on recurrent pregnancy loss. So, to start with, how do you define RPL? 2 or more spontaneous pregnancy losses before reaching the stage of viability, which is normally accepted at 24 weeks. But that is a little bit of a question mark because 24 weeks could be the stage of viability in very developed countries like USA or other Nordic countries, but it may not be true for all countries. So the viability is still taken as 28 weeks in some countries. So that is a little bit of a question mark out there. The preclinical biochemical pregnancies, non-visualized pregnancies are also included, which was not earlier. So we must pay attention that this is included. The pregnancies may be consecutive or non-consecutive. They may be spontaneously pregnant women or by ART. All are defined as RPL. We may also define RPL as primary or secondary based on primary when the woman has had no live births, secondary where the woman has had at least one live birth and then followed by recurrent pregnancy losses. And some people also like to define recurrent early pregnancy loss are those which are less than 10 weeks, and late pregnancy loss, those which are after 10 weeks of gestation. So the point to be noted is that based on this definition, even the failed visualized ectopics are included. Biochemical pregnancy losses are included, the ones which are not clinically visible, they are included. Spontaneously resolved pregnancy of unknown location is included. Persistent pregnancy of unknown location is also included. And pregnancy loss, which is suggestive of a miscarriage, but ultrasound is not performed or a karyotype is not collected, that those are also included. The molar pregnancy is not included, and live ectopic pregnancies are not included. The etiology is like a real hodgepodge and it's a conundrum really. So to make it very basic, I have tried to put in as possible causes of RPL, doubtful causes of RPL, and unexplained causes. Very often the demarcation may not be very clear. So the possible causes of RPL, as we said, we find in maybe about 30 to 50% of the case. The most important are genetic, anatomic, endocrine, and couple of others. Let me take you through each one of them and elaborate a little bit. So the genetic causes, as you have seen, is the most important cause of spontaneous recurrent pregnancy loss or spontaneous pregnancy loss in humans. And here, let me remind you of a fact that the human reproduction is remarkably inefficient. We know the black box of the human reproduction, which means that 70% of pregnancies, conceptions that ever happen do not see the, they do not survive to a live birth. And spontaneous aneuploidy is the most common cause for a spontaneous pregnancy loss and usually happens in the first trimester of pregnancy. Spontaneous fetal aneuploidies, the commonest ones are trisomies, 60%, monosomies, about 20%, and polyploidies are around 20%. And fetal aneuploidies, if we see analysis of the fetal karyotype, POC karyotype, we will see that aneuploidy is found in 90% of specimens if they abort between 0 to 6 weeks of gestation. 50% between 8 to 11 weeks and 30% in subsequently between 16 to 19 weeks and 6 to 20% in 20 weeks or more of gestation. So this shows that fetal aneuploidy, if it is present, leads to a very early pregnancy loss. And usually, if once a fetal heart is evident on ultrasound, the risk of aneuploidy is less than 5%. Other than the fact that the human embryos are inherently highly genetically unstable and aneuploid, maternal age is the one other thing which is very significantly associated with chromosomal aneuploidies. And the largest effect of advanced maternal age is seen in trisomies, which involves small chromosomes, and we know that 8, 9, 10, 13, 14, 15, 18, 20, 21, and 22. 21 Down syndrome being the one which is mostly correlated with uh, trisomy 21 or aneuploidy. So this gets us to the point, does it mean that we should be doing karyotyping for all products of conception? Are there any recommendations? Because frankly, people do different kinds of things during their practice, etc. So again, they are not clear-cut guidelines. The Green Top guideline is the one who recommends a POC karyotyping for all after a third miscarriage. But the other guidelines like ESHRE and ASRM, they do not recommend a mandatory POC karyotype. POC karyotype, apart from the cost for us, carries many other issues which we need to remember. One of the major problems being maternal tissue contamination. You see, it's not easy to keep a POC of 6 weeks or 8 weeks missed abortion and expect not to have any maternal tissue contamination. So very special different types of analysis is required to differentiate or separate chorionic villi from maternal tissue and try and do a karyotype. So generally, it's not a very easy thing to do, and recommendations at the present are not really to do them. So evidence for genetic cause of RPL are quite a few. Balanced translocations, as we know, is higher among couples with a history of RPL, 2 to 5% in the compared to in general population being 0 to 0.2%. Prevalence of RPL amongst first degree relatives of women with RPL is increased approximately sixfold, and pre-implantation genetic screening in age-matched population shows that embryos from women with RPL have higher incidence of aneuploidy. So apart from the fact that human embryos tend to be aneuploid, there is a genetic basis also for aneuploidy that we can see in the RPL population of couples. The other thing is that we have always associated genetic abnormalities with maternal age and maternal meiotic errors. But the role of paternal sperm meiotic errors and age is not very clear. Slowly, evidence is starting to coming up, and we know for sure that paternal errors are responsible for the majority of cases of sex chromosome trisomies, not for the numerical abnormalities of the other chromosomes, but in the sex chromosomes, the trisomy XXY and XYY are related to paternal sperm meiotic errors. So sperms also, the male partner also contributes to a reasonably significant number of genetic abnormality in the RPL couple. Are there single gene defects? Because till now I have only shown you evidence the fact that only aneuploidies or the chromosome number and translocation defects are responsible for RPL. Single gene defects, not much data is available, but some association with musculoskeletal gene mutations, immune system and implantation genes, thrombophilic gene mutations, etc., has been associated with pregnancy loss, but by and large, single gene defects and RPL are not so much associated. So this gets us to the point whether parental karyotyping of both the couples we should be doing. Now, this is one test which generally most of us consultants end up doing. And again, there are some recommendations. The ASRM recommends in all cases of RPL, we should be doing parental karyotyping. However, ESHRE recommends only in those who have high risk of being carriers, maybe a family history, or in which a POC has definitely shown abnormalities of translocations and aneuploidy. So parental karyotyping is an important part of investigating RPL. Now, genetic cause unfortunately has no treatment. I think the only best option for us is we should be sending them for genetic counseling to alleviate stress, and very often the genetic counselors are able to pull up a genetic family tree line and able to give us some insight. And evidence till now has not shown clear benefits of doing a pre-implantation genetic screening of embryos for aneuploidy to improve live birth in cases of RPL, neither for PGD. However, we know that gamete donation, if accepted in whichever situation that we feel right, might improve chances of a life. Now, the second is anatomic causes, which is mostly uterine anomalies. Now, this is the most important test or investigation that we should be doing, which means that in all women with RPL, we should be investigating them for looking for uterine anomalies. And we will be not wrong in going to any extent to do investigate for uterine anomalies, usually a three-dimensional ultrasound or a regular transvaginal sonography, HSG, MRI, diagnostic hysteroscopy. And we know that uterine septum is the most frequent uterine anomaly which is associated with RPL. And there are also some many publications which tell us that in cases of RPL, a transcervical resection of septum improves chances of live birth. But again, as I will be showing you a little later with my during my conclusion, that not all data has supported this fact. But I guess it is worth saying that we will be treating cases of septum if we find it as consultants, and if the woman is with RPL, we will certainly be testing it. But the question that I want to raise here is the fact that there is a big tendency for septum resection without not really being sure about what is the extent or what is the type of a septum. So I think the most important question is how to diagnose a uterine septum. And as healthcare providers, it is our duty that before taking up a patient for septum resection, we should do to our best accurate investigation to decide on the type of septum, the length of septum, and whether that septum needs to be addressed or not. There is also a tendency very often to decide to do a septum resection at the time of a routine office hysteroscopy, and that is I think not at all warranted, because very often the hysteroscopy itself, if with a lower pressure, it might give a feeling of an arcuate uterus being a septate uterus. And in any case, mild septums or small septums do not need correction. We know that very well by data which is available to us. And I think an attempt should be made, and any septum which is there is a lot of theory now about ASRM classification and ASRS ESHRE classification. Today is not the day to discuss all that, but the point that I would want to stress is that all septums do not need resection, and a proper attempt should be made for an accurate diagnosis. And a septum which is less than 1 or 1.5 centimeters generally does not need a dissection. And in my practice, I have seen at least one mid-trimester spontaneous rupture of uterus following TCRS, which was done elsewhere. And so it has to be taken with care. And of course, the septums which need correction, like a complete septum, needs to be removed. Now, the second commonest thing or the anatomic abnormality that we find is cervical incompetence. Now, this also is notorious for overdiagnosis, mostly because we have no reliable diagnostic tests. And the best diagnosis probably is a characteristic history, which you will find if you take a little time to sit with the patient and discuss exactly what happened to her during her last pregnancy losses. And although prophylactic cerclage is not really supported by RCTs, when there is nothing else to offer, cerclage is worthwhile. And office hysteroscopy and an HSG, if it does show a incompetent cervix, interval laparoscopic cerclage done at the right place, or a vaginal Shirodkar's procedure, which tightens the internal os at the right place, might be a better choice to improve chances of a live birth and actually correct cervical incompetence. Now, the other causes of anatomic defects, I will not take too much time, because we are all aware of them. And submucous myoma, severe intrauterine synecdoche, almost all of us will definitely do a hysteroscopic management for these abnormalities of the uterine cavity, because if nothing else, they will probably lead to infertility, and although they are not directly linked to RPL, but then we will treat them. So let us not go discuss that in too much of a detail. Now, the next is endocrine causes. Now, again, like anatomic and genetic, this is a vast area, and I can rarely, I can simply not discuss them in a single lecture. So I thought I'll just make some important points and see if I can put in some, worthwhile things to take home. Well-controlled diabetes and treated thyroid dysfunction is not a risk factor for RPL. 36 to 56% of RPL women have PCOS. High LH is not a cause of RPL. Women with PCOS who miscarry generally have high androgens. Oligomenorrhea was 10 times more important than any other risk factor in predicting recurrent pregnancy loss. Insulin resistance is prevalent in RPL. Fasting glucose insulin ratio may be considered in women with RPL and PCOS. Metformin continued during pregnancy to prevent RPL has been well supported by data. Hypothyroid, certainly an overt hypothyroid has to be treated. It is associated with RPL. But subclinical hypothyroid also should be tested by testing for antithyroid antibodies because antithyroid antibodies may certainly be expected to be associated with RPL and premature delivery. Therefore, although the recommendations again are not very clear, so I am not going there, but I think almost all of us will test for thyroid function and will treat subclinical hypothyroid. What I would like to stress is that we should also be testing for thyroid antibodies, anti-TPO antibodies. Now, PCOS and RPL, like I showed you in my previous slide, is massively associated. Only we do not know what is the cause or what is the treatment of RPL and PCOS. Now, the next is the immunological factors. We know that they are basically autoimmune and alloimmune. Autoimmune is immunity which is directed towards self. Alloimmunity is directed to foreign tissues. I'll come to that a little later. Autoimmunity is now one of the most important causes of recurrent pregnancy loss. We know that systemic lupus erythematosus, SLE, and antiphospholipid antibody syndrome. So let me just elaborate a little more on this particular type. There are many types of autoantibodies: anti-nuclear, anti-cardiolipin, anti-phospholipids, anti-glycoproteins, etc., etc. But it is the antiphospholipid syndrome which is the most common cause of a recurrent pregnancy loss. Now, to make a diagnosis of antiphospholipid syndrome is the tricky part. It's easy to do just one test and do, but we have to be very sure that the women who we are thinking of as antiphospholipid syndrome is actually antiphospholipid syndrome. So the recommendation is that we should have at least one clinical criteria and at least one laboratory criteria for us to be able to put that patient as antiphospholipid syndrome. The clinical criteria is recurrent loss less than 10 weeks without a heartbeat or with a heartbeat, fetal death unexplained more than 10 weeks, history of venous thrombosis or arterial thrombosis in the woman, and also history of intrauterine fetal death following severe preeclamptic toxemia and severe IUGR. Any one of these clinical criteria if present. Laboratory criteria if there is presence of lupus anticoagulant and anti-cardiolipin IgG, IgM, and anti-beta-2 glycoprotein. So these are the three laboratory tests: lupus anticoagulant, anti-cardiolipin antibodies, and anti-beta-2 glycoprotein. One. And not only they have to be positive, they have to be positive at a high titer, which means at least at a 99th percentile. And also, they should be repeatedly come positive after a gap of about 6 weeks to 12 weeks of time. And the three antibodies I said only should be tested. There are so many antibodies, huge panels that are promoted by these, pathology laboratories, which generally are not required, and only these two antibodies should be tested. And we know that antiphospholipid antibody syndrome, if there in your patient of RPL, will give you one of the best life birth or best outcomes, and it will really satisfy you. And of course, we know that the treatment is low dose aspirin, 75 to 100 milligrams, and a low molecular weight heparin, 5,000 IU twice a day, up to 34 weeks, and it's a good success rate. So that is about antiphospholipid. Now, these causes that I have told you till now are possible causes, and they have been pretty much supported by a reasonable evidence that is available out there. But then there are many other causes which also are coming up as possible or doubtful causes of RPL. Here again, we have like too many, and we cannot be discussing each one of them. So let me just elaborate on the important points and try to give some important take-home messages. Mild intrauterine adhesions, subserous fibroids, arcuate uterus, unlikely. Luteal phase defect, big question there, but never been supported. Endometriosis, not supported by evidence. Alloimmunity, I'll come to it a little later. Environmental factors are coming up and they are really important. So let me discuss with you a little in detail. Now, one must remember that there is no evidence that viral or any bacterial infection can cause RPA. There is no convincing evidence against endometriosis or LPD. And therefore, performance of torch test, which again I want to repeatedly give out this message, that torch is a test which is very often, prescribed by gynecologists, and the evidence would suggest that it is invariably uninformative. It is of no value at all to be doing a torch test during evaluation of a RPL patient. And therefore, similarly, culture of various different viruses, bacteria, vaginal swab culture, blood culture, etc., are not at all recommended. Now, in the doubtful causes, there are three factors, 3 points which I want to elaborate today, which I have named as emerging causes of RPM. Male factor, lifestyle factors, and chronic endometritis. This is an interesting picture. Have a look. This is a Venn diagram of the responsibility of reproductive failure. Now, when a conceptus fails to implant or fails to become a live born, full blown child, who is responsible? In 80% of the cases, it is the egg. In 10%, it is the uterus. The sperm also is 10% responsible. However, all these years, somehow male factor and recurrent pregnancy loss have not received the kind of attention that they should be receiving. And now, over the couple of years, we know that there is a lack of consistent association between conventional semen parameters. In fact, now we know that conventional semen parameters barely tell us much, whether it is for infertility evaluation, whether for pregnancy loss evaluation, they barely tell us much. And therefore, Y chromosome deletions like male genetic defects and chromatin integrity and DNA damage in the sperms have started gaining importance. And although it is not out there and become as a very common practice till now, sperm DNA fragmentation, and not many of our colleagues might agree with me when I say that sperm DNA fragmentation also is an important part of investigating RPL. The current ESHRE guidelines do tell us that there is a moderate body of evidence indicating associations between RPL and poor quality sperms, particularly with elevated DNA fragmentation. So the current guidelines says that although we simply, as I will tell you, there's no treatment, there's no clear diagnosis that you can give your patient, but this has been associated, and it might be a good idea to assess the male partner apart from the lifestyle factors like smoking, alcohol, exercise, and body weight. We know now that at least smoking and excessive alcohol consumption, excessive body weight, BMI, both in the men and women, can lead to recurrent, it can lead to infertility and apparently also to recurrent pregnancy loss. Exercise pattern is like excessive exercise in the woman as well as men has been linked to recurrent pregnancy loss. Assessing DNA fragmentation can be considered based on indirect evidence. This is what the current guidelines tell us about sperm DNA fragmentation. My group from my hospital and my lab, we have published 4 high impact papers which deal with paternal factors and recurrent pregnancy loss and have received a good update about the same. Then comes environmental factors, the role of endocrine disrupting chemicals. Again, today is not the time where we can, this is a huge chapter again. And we know that, and today is just not the day where we can go into the details. But yes, environmental contaminants, and there are some professions which are at high risk. confirmed association is with ionizing radiation that everybody knows, but many organic solvents, alcohol, mercury, lead, caffeine, cigarette smoking, anesthetic gases have for long been thought of, though till now not confirmatory. And dentistry, which has been associated with acrylic compounds, mercury, solvents, etc., have been associated with increased miscarriage. And this was a fantastic paper, which I have no time to discuss today, which showed lifestyle and RPL, and they showed that many of the endocrine disrupting agents, chemicals that we find in our everyday use items have many hydroxy carbons and organic like plasticides and pesticides, etc. They have many compounds which are defined as xenobiotics, and therefore have been linked to many of the uh, human reproductive failures, be it infertility or spontaneous abortion. Then the final of my emerging causes is endometritis, which again is a new area which people have started investigating as a link to infertility as well as recurrent pregnancy loss. And we in India know about active cocks, but I will not go there because there is not much evidence. But then endometritis and RPL, there are quite a few studies there. So when we have taken up our patient for of RPL for diagnostic hysteroscopy, we should also be looking at hysteroscopic picture suggestive of endometritis like micropolyps, strawberry endometrium, edematous endometrium, plasma cells in histopathology, and immunohistochemistry also can tell us. Now these are some papers that support mm, the chronic endometritis. And then luteal phase defect. I think let's not go too much into the details of luteal phase defect. This is a highly doubtful cause of RPL, and especially with the availability of progesterone and HCG, which are very rampantly prescribed for patients of pregnancy loss. We would think that if luteal phase defect was a major cause, then that would take care of it. But all the evidence till date, this is a very old thing that I have shown you, reference. However, all recent reference also says that progesterone or HCG for adding for recurrent pregnancy loss is unlikely to help result in increased chances of a life. And then the C was unexplained causes of RPL. We know that majority of our patients, after spending quite a bit of money in the tests that we tell them to do during our evaluation, still will have no satisfaction of knowing as to why they are aborting all pregnancies. Um, Unexplained many causes could be there, but we don't simply have enough publications on that. The various thrombophilias, which result in implantation failure, could also be recurrent pregnancy loss causes. Poor ovarian reserve, hyperhomocystinemia, endometrial factors, biochemical or gene expression factors, sperm and oocyte factors could be there. But however, we must remember that alloimmune immunological factors, the fact that the fetus is actually a allograft with it's a foreign graft which is comfortably invading into the maternal tissues and establishing a establishing a blood flow with the mother and invading deep into the maternal tissues itself is a big surprise. And it is possible that defects out there in the interface between the placenta and the invading fetus are the many causes that could lead to recurrent pregnancy loss. And we simply today cannot take into discussion the alloimmune factors, which itself is a big chapter to discuss. So to summarize, I have just made a couple of take-home messages. First, counsel the couple about the impact of the following factors in RPL: maternal age, smoking, tobacco, alcohol, BMI, and stress. You have to tell them that a mother at the age of 42 will have a much higher chances of abnormality, somebody who's a smoker, etc. And put all your patients on folic acid and vitamin D supplementation. Useful investigations that I would tell all my RPL patients would be: assess the uterine anatomy, 3D TVS, HSG, hysterolaparoscopy, and MRI if needed. Do the antiphospholipid syndrome panel, which means anticardiolipins, IgG and M, lupus anticoagulant, beta 2 glycoprotein, thyroid function test, thyroid antibody, and sperm DNA fragmentation may be considered. Following investigations may be considered after risk assessment and for explanatory reasons, like parental karyotyping. POC karyotyping, highly doubtful, but depends on your patient, you may consider in a particular pregnancy loss. Hereditary thrombophilias also may be considered if the patient gives a history or if you deem it necessary to do it. Now, treatment choices, we have very few choices to improve life birth. Reassuring the patient is the most important treatment you can give. And let me, before about the rest, let me just show you this graph, which is very, very important to share with our patients who will understand it. Now, this is a graph which shows us that for a woman, after 3 pregnancy losses, what are her chances of a live birth after so many years? So, to put it simplistically, after 5 years that a RPL patient has consulted you, if she has 3 abortions, she has a 75% chance that she will have a live birth within 5 years. If she has 6 abortions, she has a 55% chance that she will have a live birth within 5 years by whatever treatment you do or whatever treatment you do not do. So reassuring and prognosticating based on her age and number of previous pregnancy losses will go a long way in, treating these people. Antiphospholipid, we know how to treat. Correction of cavity factors, cervical encerclage where needed, septate uterus, gamete donation, I have discussed all that. And treatment choices which are not supported by evidence, giving progesterone, HCG, metroplasty for bicornuate, unicornuate, didelphys uterus, etc. And IVIG, intralipid, glucocorticoids, GCSF, peripheral blood mononuclear cells, PRP, etc. And also IVF, TISA, and PGS. These treatment choices are not supported by evidence. Thank you so much. I hope I was able to give some take-home messages out of this a lot of confusing talk that I have given you. And ultimately, we have to decide and choose between tender loving care and the need to do something. Thank you very much.
That was a very excellent lecture by Dr. Sujata Kar. Before we go to the question, Tejas, can you share this screen, please?
My screen?
No, no, no.
Stop.
Tejas has to screen. No, no, no. Can you show us? Yeah. So I would like to thank again, once again, the Zydus Gynec division for supporting this particular event. Can I have the next slide, please? So I wanted to inform everybody about this Sadhana Desai Endowment Fund, which is Dr. Sadhana Desai has donated huge amount of money for eligible couple who require IVF-C, who are in need of financial assistance. Next slide, please. So they can be given up to 50,000 rupees, but this initiation of this application has to be done by the doctor. And if you go to ISAR website and look into it, you will be able to help your patient. Next slide, please. Then we have this JHRS journal, which is doing extremely well with a high impact factor, and it's covering almost all aspects of human reproduction, including pre-implantation, genetic diagnosis, ethical, legal issues. Next slide, please. Dr. Madhuri Patil is a current chief editor. It is a journal which has around 40% overseas subscription with a very good impact factor. I will urge everybody to think about our own journal for publication. Next slide, please. And this is about the ISAR accreditation, which we are going now with the advent of virtual accreditation. So with that, there will be no visits at the center. Everything will be done by accreditation. This accreditation will be valid for 3 years. Next slide, and it will cost you around 25,000. And these are the zonal coordinators which will you need to get into contact for getting the accreditation done. Thank you very much, Tejas. Now, let's get back to Sujata Kar for questions. Oh, wow, lots and lots of questions. Okay. So,
Yeah.
the first question is from the bank, I'm asking you now. How many
Hmm.
losses are subjectively contribute to RPL? Role of chromosomal abnormality in RPL. This is from Mumbai.
How many? Two or more?
Two or more. Okay, very good.
Yeah.
And role of chromosomal abnormality in RPL is a question. So I don't know exactly what is the question, but you may
In
answer.
early RPL, it will be almost in less than 10 weeks if you are getting RPL. Mostly 75% will be associated with genetic abnormal, chromosomal abnormal.
Okay. If next question, if we get a report no intact DNA material seen despite a good amount of tissue, what precautions should an embryologist take? Some emphasis on PGT on reducing recurrent pregnancy loss.
No, I
So I
didn't
have not
understand.
understood. The first part, I think we should not consider. The
Hmm.
second part we should consider is emphasis on PGT on recurrent pregnancy. So what she wants to know is which particular aspect of genetic abnormality can be held by PGT. This is from Delhi.
So, if you have unexplained recurrent pregnancy loss, then the
Mhm.
rationale of doing a PGD is to at least not put in aneuploid embryos. You have to make sure that you have a euploid embryo and then put it. So
Okay.
that is the only rationale for doing it, but that has not been supported by any uh,
Evidence.
evidence.
Evidence. Okay. Now, from Aligarh, Dr. Charu is writing, it's a case. She has written fourth gravida with one living issue, fourth gravida, one living issue with two term losses because of recurrent abruption. No history of high blood pressure or GDM. Anticardiolipin antibody titer shows normal. IgG and normal IgM. IgG is increased. I think our anticardiolipin antibodies. Now she is 8 weeks pregnant with small subchorionic hemorrhage. Do I need to start low molecular weight heparin or ecosprin or any other advice?
No, I don't think low molecular weight heparin is what is the problem in this particular case, because she has very late trimester
Yes.
abruption, and
Hmm.
she does not have history of preeclamptic toxemia or IUGR. Then
Yes.
placenta, yeah, it has to be some other
Okay.
factor which is linked to recurrent unexplained abruption. So
Okay.
no, no low molecular in my opinion.
So, what would you recommend for this patient? Maybe
Patient
preconception
is,
folic acid?
wherein there is unexplained abruptio, I would recommend to deliver earlier as far as
Earlier.
possible.
Okay.
35,
Perfect.
36 weeks.
Give a steroid dose and take it out. Correct.
Yeah, yeah, yeah.
Now, the next question is role of steroids. If it is administered, what should be the duration and how to taper? This is from Gujarat. So you're getting from all over the India. Very nice. So what is the role of steroids if administered? If you administer or if anybody administer, what should be the dose, duration, and then how do you taper it?
So there is no role of giving steroids for recurrent pregnancy loss. I mean,
Okay.
dexamethasone or none of those are supposed to be given.
If I may ask you one question, If
Hmm.
the patient has, say, ANA DNA positive but APLA negative, is this category becomes applicable for steroid? Do you consider?
Actually,
No.
my personally, I don't have much experience of doing anti-nuclear antibodies and
Okay.
anti-DNA antibodies, so I cannot say. But apparently, no. When we have nothing to do, we can do tests
Huh.
and give, but it has not
Try to
been.
find something abnormal. What you say is
Yeah,
correct. How
yeah,
do you counsel when PGTA embryo, A is capital, fail to
aneuploidy.
implant, fail to implant, and what is the percentage it can happen?
So why does a euploid embryo not implant? That's what he's asking.
A embryo, I think, aneuploidy embryo, I think.
So PGTA is when you're doing a PGT for aneuploidy, and then when you check that is not aneuploid, and then you do a embryo transfer, and still
Okay.
they do not implant. I think that is what he's asking. Actually,
So
we
what
do
is
not know why that happens, because so
okay.
it obviously means that other than aneuploidy, there are many other causes
Other
why a
causes?
implantation will not happen.
Okay. This was from Murli Haridwar. Okay. There is a very nice comment somebody has left from Calcutta saying that it was a great presentation. Congratulations to you. There's
Thank
another
you.
one, the excellent presentation from Dr. Rashmi from Mumbai. She says, if all embryos after PGT in RIF patient, if embryos are abnormal after PGT in RIF patient, how to proceed?
All the embryos are in one cohort. All the embryos are.
Abnormal.
That's a tricky one. So I guess you will, if the patient is willing, you will try another cycle. Next cycle, she may have, or if her history is such, then you have to consider a donation, gamete donation.
Okay, that will be correct.
Yeah.
Mhm. Which therapeutic intervention should be offered to the couple when RPL is due to genetic chromosomal causes to increase live birth rate? This is from Solapur, somewhere in Maharashtra. So
So
she's
let's say
asking for genetic abnormalities. What can you offer? What intervention, therapeutic intervention? So, what can you offer?
is there a specific genetic abnormality that is there in the couple? Then
No,
we
there's
can.
not. Yeah, what you say is correct. Go ahead, go ahead. You can
So
answer.
if one partner is showing a Robertsonian translocation, or or something like that, if what she's asking, I don't know. But I
Hmm.
guess the easiest way is to send them for genetic counseling, number one,
Correct.
and then you have to just reassure. But doing a PGT is not always the answer.
Okay. Now, if I ask one question to you, that what do you think is the role of microarray in evaluation of genetic abnormalities in a couple?
Microarray technique.
No, no, no. What is the role? When would you, if at all you have to offer a patient a microarray, hmm, when will you when will you, or do you advocate microarray?
No, I am actually not understanding the question. Microarray is a technique by which you evaluate the genetic material. I am thinking. I am not a embryologist or a lab person.
No, no, no.
So,
I'm asking you, which set of patients
huh,
would you recommend a microarray testing? Do you
on
recommend
a
any?
karyotyping.
Huh?
You mean to say karyotyping of the couple?
See, karyotyping ho gaya. Karyotyping is normal.
Hmm.
Do you, over and above that, do you go one step ahead and offer them microarray as a new technique?
No, frankly, I cannot answer because I'm not knowing what is the meaning of doing a microarray following a karyotype. So maybe a lab person or a geneticist will be able to answer.
See,
I thought
what
microarray was a technique.
no, the technique is microarray for finding out a particular gene disorder, but let's
Uh,
leave it at that time. What
yeah,
is
yeah.
the
It is about the single gene defects that you
yeah,
were talking about.
yeah.
Hmm.
What is
So
the value?
maybe then the genetic counseling, and then if the patient has a history,
Yes.
let's say there
Hmm.
are people with Duchenne's muscular dystrophy, etc., and all those, maybe that kind of people you can think of.
Hmm. Very interesting. What is the value of thrombophilia screening in a woman with RPL?
Generally, it
This is
has
from
not been.
Ahmednagar, Gujarat. Hmm?
Yeah,
It's
generally it would be indicated
Mhm.
only if the patient has typical history of a severe IUGR, severe preeclamptic toxemia, or has history of thrombosis in the past,
Mhm.
um, or recurrent implantation failures. Those kind of, if somebody has a history, that would be the best. Those kind of people, but as a routine to do them is not very useful.
Hmm. So there is one question from my end now.
Hmm.
If there is a polycystic ovarian syndrome, okay,
Hmm.
so in your presentation you've written the high androgens may be the cause of abortion, or it could be obesity. So in a PCOS, if you want to improve the outcome of PCOS patient, how do one go about in a patient of recurrent pregnancy loss? If there is nothing else, only PCO recurrent pregnancy loss is, the only positive finding is the patient is PCO. So would you advise us something?
So that is
Maybe.
the whole thing which I have shown, is that the PCOS and RPL are associated. Only we
Hmm,
do not know why. But the fact is, as you mentioned, a lot of them will have high androgens, which is part of PCOS.
okay,
So I don't know how to answer your question, except for maybe make some lifestyle changes in your patient. If she's
okay,
obese and PCO, you can tell her losing weight will reduce your androgens, and
correct.
insulin levels, and things like that. Other than that, there is not much.
Not much you can offer. ठीक है.
Hmm.
Does aspirin in APLA, do you recommend 75 milligram or 150 milligram?
75 was not, we used to always give 75. It was not available for a long time, so we were writing 150. I still
Mhm.
now also I'm writing 150, but the
One
recommended dose is 75 to 100.
100. Okay.
Hmm.
Now, this is a very different question. In lockdown, if a patient stuck with recurrent abortion, okay, okay, the first blighted, now 11.4 with abnormal NT.
Acha.
So some epigenetic testing not possible, or what, I don't know. Epic testing is not possible. What to do next? This is from Delhi. Munir.
Now, if she have, I think
So
what he's meaning, there is an abnormal
one
entry. He would like to do
yeah,
a biochemical test like a double marker
yes,
or a
double marker,
quadruple marker or a NIPT.
NIPT,
So
correct.
non-invasive that, if that is not available, then maybe amniocentesis at 16 weeks.
Hmm. Yeah, that will be something better. Yeah. Now
Hmm.
there is a lady who is asking about throw light on the use of Bharglow. This is from Vinita Naik, Chhattisgarh.
I have never
Bharglow.
personally prescribed it. So I think it is a immunoglobulin, right?
Yes, 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 immunoglobulin.
Yeah.
It's like torch meal, that people believe that this works. So they
Yeah.
swear by God, you are giving RPL, let's say
I
you
have
come down
actually
and they will
no
ask you.
personal experience in it.
I
Never
understand.
prefer.
In which cases would you recommend a cervical encerclage in ART pregnancy? Rohini Nayak, Bhubaneswar. So she's
Mm.
asking which
In
ART
ART pregnancy,
pregnancies,
I
when
would
do you
consider,
uh,
I think she is meaning prophylactic cervical cerclage. In an
absolutely, yes.
ART pregnancy, which is a twin pregnancy, and
Okay,
at 14 weeks, cervical length, if is inadequate, less than 3 centimeters,
okay,
I might consider.
okay. Mhm.
But
So,
again, like we know it, that cervical encerclage is a procedure which is done we overdo it often. We have to accept it. and we really do not have any evidence to show whether it helps or it does not help.
Mhm. So, versus sucklage versus vaginal progesterone, which is a very new topic, controversial topic going on for last 2 3 years for short cervix.
Yeah,
So,
yeah.
do you use vaginal progesterones?
I do that. So when the patient books first, then we
Mhm.
generally, after taking her history, if she is at risk for preterm labor,
Excellent.
then
Hmm.
giving her either a weekly proluton depot
Okay.
or a vaginal progesterone is what I follow normally. Cervical encerclage is for a very prophylactic encerclage. I mean, somebody who's never had a previous history suggestive of a cervical incompetence is very,
Hmm.
very less for me. But I might give it only if the cervix is very short, less than 2.5 centimeter, and confirmed by vaginal sonography, and is has a twin pregnancy. Very rare situations, but I very often give vaginal progesterone up to 32 weeks as a prophylaxis for PTL.
Then next question is when and till what duration of pregnancy do you give low molecular weight heparin if somebody gives? So they want to know
30,
about low molecular weight heparin.
32 to 34 weeks.
32 to 34 weeks. Okay. So around the same time you stop aspirin also, Sujata?
Yes.
Okay, good. So there is a case now, Gravida 5, abortion 3, Para 1, living 0. 3 consequent first trimester abortion, 135 weeks IUFD, no cause detected, parental karyotype normal, now spontaneous conception 8 weeks. Please guide please guide the management in the pregnancy. TVS is normal. Big profile is normal. 25 BMI. Is
Hmm.
from Barodra, again Gujarat.
Yeah. So I think since the patient has come and consulted when she is already pregnant,
Hmm.
making a diagnosis of antiphospholipid syndrome will be difficult.
Correct.
But because in pregnancy you're not supposed to test for those antibodies and lupus anticoagulant, etc. But I guess she can test for APS, antiphospholipid antibodies, and because in any case, giving heparin and aspirin, the earlier you start, even before heartbeat has come, it is better.
Hmm. Okay.
Now, she has no choice. I would certainly start her on both low dose aspirin and low molecular weight heparin. I would also start her on a progesterone. Given her
Now,
history, she has three abortions and one late
I
full term IUFT following pre-eclamptic toxemia or something. So with that kind of a history,
hmm.
without a I think I would do this.
Okay. Now,
Although there are no right answers, I'm sure they understand.
so there are some questions from my side to you now. I want you to discuss about a role of bed rest. Can you emphasize on something on bed rest? People in
Uh,
all RPL patients are recommended bed rest, even if the spontaneous abortions happened at 8 weeks. So, what is your take on bed rest?
I do that a lot. I ask for bed rest a lot because bed rest is something which I ask for bed rest and abstinence both.
Okay.
So again, I don't know if there is any scientific reason how I
Okay.
can, collaborate it. But putting women on a bed rest, I think is a very very commonly practiced
So,
option.
if I ask you, is it a complete bed rest with like 24/7 or 2 hours in the afternoon, 8 hours at night, and home
So,
confinement?
so if she is a case of recurrent pregnancy loss, which is suggestive of any anatomic like cervical and given and all that, in that case, it is absolute bed rest, which means only toilet, bed, and food. But if
Okay.
it is like not that kind of a history, then I think, like you said, at least 10 to 12 hours in bed
Hmm.
every day is what we would recommend, and not
Okay.
do any strenuous work.
Okay. Okay. Then, how do you what you called you know you had written something about reassurance to the patient. Okay, so
Yeah,
what is your technique? This is from my side. Huh? What is your technique of
yeah.
reassuring the patient? Since you are a great
So when
artist.
the patient comes,
Mhm.
there are women, we know, we see patients Kedar all the time, and we know that there are couples with one missed abortion. Also, they are so distressed
Okay.
that they really need reassurance. So
Mhm.
generally, I tell them that with one is very, very common. Like you get it almost 25% of the first pregnancies are spontaneously lost in the early trimester. It's very common. The chances that the next pregnancy will be very good is as high as 85%.
Mhm.
Similarly, by reassurance in RPL, I meant to show you that graph and
Mhm.
trying to tell them that unfortunately, although lots of expensive tests are available, the point that we
Mhm.
will be able to find any cause is not very high. And even if we find a cause, the fact that we will be able to successfully treat is not very high. However,
Correct.
nature may be spontaneously able to throw up a pregnancy which is genetically correct and is in a right environment at the right time, and that
Correct.
pregnancy is going to get you a full life birth. And this is the statistics. If your
Mhm.
age is good, the fact
Mhm.
that if you do not do basic tests but no treatment, if
Mhm.
you've excluded all major causes, the chances
Mhm.
that you will spontaneously have a live birth in
Mhm.
3 to 4 years to 5 years is this high. I think
Mhm.
that's goes a long way in reassuring. But after 5 or 6 early missed abortions and late IUFDs, I
Mhm.
always address them on gamete donation. I don't know if everybody agrees or not.
Yeah, that's the way you think, isn't it?
Yeah.
Now, somebody asked me about RPL and unicornuate uterus. This is from Latha. So she wants to
So
know about
RPL
unicornuate
and
uterus.
unicornuate uterus, to the best of my knowledge, have not been linked. Unicornate uterus may be associated with premature delivery, but
Yes.
then, let's say that where the uterine abnormalities are concerned, the
Mm.
Mullerian abnormalities, they are so varied, and
Mm.
sometimes there are so many different kinds of hybrid abnormalities also,
Mhm.
which we are not able to test or not able to pinpoint. They may be
Mhm.
different, but otherwise unicornate uteruses are not associated with recurrent pregnancy, loss of the first trimester. Now,
Mhm.
maybe preterm delivery and that leading to early neonatal death, that is, I think, different.
So there's one more question. If there is a patient who has, say, blighted ovum at 6 weeks or missed abortion, so normally, how do you manage this abortion aspect? Do you do a surgical evacuation, or you wait, or you do medical abortion?
I think it will depend on the ultrasound finding. If the ultrasound finding blighted ovum, she said, and no yolk sac or fetal pole or anything, and with a poor decidual reaction at 6 weeks sac, most of them will expel with a medical option.
Okay, very good. So you will not always go for a surgical operation, correct? No?
No, only.
Yeah. Okay. So there is one person is asking, what is the role of spiramycin in toxoplasma IgM positive patients before and after conception?
Hmm. It's okay. So if it is a confirmed case of toxoplasmosis in pregnancy, then
Mm.
spiramycin you have to give in the routine way prescribed 3 weeks on, I think 2 weeks off. I don't have too much experience. I may be a little wrong. And then you have to give it throughout the pregnancy.
Okay. But
When the patient is, uh,
no, because this is written by Sushma, and Sushma, if you knew the toxoplasma IgM is positive
oh, IgM,
before,
huh.
IgM is positive, and she's written before and after conception. So before conception, I think one should wait for IgG to become positive, isn't it,
Hmm.
Sujata?
Yes.
Right?
So,
Yeah. So one,
firstly, I didn't go there because I thought if it is a confirmed case of toxoplasma. Now, if it is only IgM positive at any time, that doesn't give you a diagnosis. You have to
correct.
repeat the titer, you have to repeat it again
Yes.
after 1 week, 2 weeks. You have to do a avidity study. There are so many things you have to do to
Yes.
confirm active torch infection,
Mm,
toxoplasma infection.
absolutely.
But once
So,
the active toxoplasma is confirmed, then you will give the spiramycin. No?
but what is the WHO recommendation is not to screen only
Yeah, that's what.
for first trimester losses.
Yeah.
Okay. Now there is one gentleman has written from Silvassa, myo-inositol, does it help to improve the egg quality?
Myoinositol has nothing
Basically,
to do with.
insulin sensitizers, those insulin sensitizers help in improving the egg quality in
No.
PCOS. No. Okay. What is your take on role of antioxidants, empirical antioxidant, you can say, in patients with recurrent pregnancy loss? Because sometimes you see a prescription, you have thoda sa HCG, thoda sa progesterone, thoda sa estrogen, thoda sa steroid, thoda sa heparin, thoda sa bed rest. So,
Mm.
what is your take on such things? How should we go
So
about?
antioxidant during when the patient is pregnant, I don't
Okay.
prescribe.
No, pre-conception.
Periconception, if in the men, if there's a suggestive history like smoker, tobacco use,
Okay.
and all that, I will definitely prescribe a antioxidant or a sperm count which is suggestive or a DNA fragmentation which I routinely do for RPL. I will definitely do it. But sometimes for want of doing something, folic acid and for men, I will definitely very commonly write an antioxidant. Again,
Hmm. And
not very.
what about this folic acid versus L-methyl folate thing? So a lot of companies are coming up and saying for hyperhomocystinemia, L-methyl folate is little better. So do
Hmm.
you have some take on it?
Actually, I wouldn't know. I don't
Okay,
know the details, but I think it makes sense that L-methyl tetrahydrofolate is a more active form, so it might be better.
absorption will be better.
Hmm.
So this is where my personal questions and from the bank everything is over. And we congratulate you and thank you very much, Dr. Sujata Kar, for taking out time and taking this wonderful presentations. Uh, we again thank the Zydus Gynec Division and DocMode for supporting this program.
But
Anything?
mostly thanks to you and thanks to Dr. Prakash for giving me this chance. And of course, Zydus, they are really very professional. Huh? They are doing it fantastically. So thanks to
Absolutely. Yeah.
thank
Hmm.
you. Thanks a
Thank
lot.
you. Tejas, thank you very much.
Thanks, Tejas.
Tejas,